Welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Lineberger Cancer Network. I want to say thank you to all of you who are here. Thank you all for your patience while we sorted out a few things, and I think we've got everything working now. If you are having any technical difficulties, call us 919-445-1000. You can email us, unclcn@unc.edu. We do have people standing by, and they can help you sort out any problems. Worst case scenario, your bandwidth fails, your computer and phone just won't cooperate. We are recording this. It will be a 4-credit enduring material in addition to the live event. So we'll make sure that you can see this whole presentation and that you're able to receive credit as well. We will be using Poll Everywhere. That makes it interactive. Linnea will be asking you some questions. You can respond. And then at the end of today's presentation, you'll have an opportunity to ask her questions. All of that happens through Poll Everywhere on any browser, your phone, your computer, your tablet. Go to pollev.com, pollev.com. Put in the letters UNCLCN, and then you can respond to the questions and ask your own questions at the appropriate times. We know that many of you are wanting to get credit for today's live presentation. So you can do that by joining in Zoom. Make sure that you're seeing the slides and all the video and everything, the full presentation. If you're with a site coordinator at a designated site, that is fine as well. One of those needs to be happening. If you're just joining only the audio on Zoom or just watching the live stream, not in Zoom, we can't give you credit for that. You'd need to do the enduring material. Additionally, we need you on for a full 50 minutes, and we need to ask you to fill out an evaluation and select a certificate and to claim your credit within 7 days. And of course, you can reach out to our help number or help email if you run into any trouble with that. As soon as, just wait to claim credit until we end the Zoom video. As soon as that happens, you should be able to go ahead and claim your credit. Let's see, what else can I tell you? Lots of different series. Our patient-centered care series, that's this one. Our advanced practice provider series, that's next week. Research to practice the following week. Our CICEP series, we've got a new February CICEP lecture coming up. Lots of different events, lots of free continuing education throughout the year. The umbrella, the kitchen, and the kitchen table, providing safe, supportive care for cancer patients with Linnea Van Pelt, BSN, RN, CMSRN, OCN, LMBT. So this is our presentation for January 11th, 2023. Oops, one slide too far. Linnea Van Pelt has been a nurse at UNC Healthcare since 2010, working with oncology patients in some capacity for her whole career. After achieving a lifelong dream of becoming a licensed massage therapist, Linnea pursued an opportunity to join the Comprehensive Cancer Support Team in the Patient and Family Resource Center, what we call PFRC, in 2021, which to her felt like a dream job come true. Here, she found a team that was truly dedicated to whole person and family care and a place that felt like a true home away from home for patients that she had previously cared for in the hospital and clinic settings. Linnea became manager at the PFRC in 2022 upon the retirement of her longtime predecessor and is looking forward to continuing to grow and integrate this essential support structure and programming that serves so many patients at vulnerable times in their lives. Linnea lives in Graham and is married to her wonderful and hilarious husband, Jeff, and they have 2 children, Eva, 9, and Ethan, 6, and a crazy new Australian Shepherd puppy named Rocky. Linnea, welcome. Thank you so much for being here today.
Thank you, Tim. Thank you all for having me. This is a true honor. And thank you for both you and Andrew for navigating the technical difficulties we had just now. I would be a ball full of stress if it wasn't for you two. So,
well, we're happy to help, and we're very thankful for our audience here today. What's something we should know about you outside of your professional bio and family?
Well, I was actually going to talk a little bit about my crazy Australian Shepherd puppy, Rocky, who gets to go to work with my husband every day. My husband works on a golf course. So Rocky goes with him to the golf course every morning and chases the Canadian geese off the greens. Um, my true kind of pipe dream, pie in the sky, is to someday have a puppy that I can take to work with me as well in the Patient and Family Resource Center. Probably a much calmer breed, maybe a golden retriever that can just give some canine love to our patients who come here, because we all know how immediately impactful and wonderful that can be.
Absolutely. Oh my gosh. And we're big supporters of Pets at Work at Cancer Network. My dog Ruby is immediately to my left on the floor by me, and most of our team have cats and dogs that are our coworkers. So that sounds like a great goal. Let's see. I mentioned we're going to use Poll Everywhere. We try to start off with a softball. The umbrella and the kitchen table are metaphors in today's presentation. True or false? So we'll give everyone a minute to take a shot at answering that one. And while we're doing that, I'm just going to flash up this disclosure, which I used to have to read word for word, and I no longer have to. So I think I've left it up for the required amount of time, and I'll go ahead and move on. Well, darn, I thought you were going to talk about umbrellas and kitchen tables today, but it looks like these are metaphors. And it looks like our audience is sold on that fact, so that's great, the umbrella and the kitchen table. And I will get out of the way and turn it over to you, and we'll find out what those are, what the metaphors are.
Awesome. Well, thanks again, Tim, for the wonderful introduction. And hello, everyone. I am, strangely on my cell phone, so I don't see any of your faces, not even little boxes with U numbers or anything. So I trust that you're out there. And I really hope that you enjoy this presentation. This is really a big honor for me to be presenting today to an audience of this size and this scope. So I appreciate the invitation. And I'm just grateful for the opportunity to share a little bit about this cancer support community that we are building, that we have been building for many years here at UNC and really across the state of North Carolina. And I hope that today's presentation will either confirm or maybe build on some of what you probably already know inherently or in the work that you do. And that is that comprehensive and holistic care is just so important when we are caring for cancer patients. But I also hope that this presentation maybe opens up a new area of inquiry for you as you consider kind of the real life, everyday implications of having a cancer diagnosis and navigating the treatment for it. And even better, learning a little bit about how we can improve the type of support that we offer our patients who are facing it. I don't have any personal conflicts of interest to disclose either, so I'm excited to get started. Thank you, Tim. So our goals for today are pretty simple. Our time, of course, is relatively short, but I do want to encourage you to, use the poll everywhere to ask questions kind of as they come up in your mind, so we can start there when we get to that part of our time together. We're going to start with a couple abbreviations and definitions. I'm also going to share a little bit about why I personally believe that metaphors matter in the medical field and why I think they can be a really powerful learning tool, not just for our patients and their caregivers, but for us who provide that care in the medical setting as well. After that, I'm going to invite you to learn a little bit about why supportive care matters. That's why we're here, and why it's essential and not complementary care when you are attempting to provide comprehensive and compassionate care. And after that, I'm going to invite you, metaphorically, of course, to find a nice dry spot under the umbrella to journey a short way to a little home away from home in the PFRC and pull up a chair at our kitchen table. So as you can see, our learning objectives, of course, you're going to see these again later in the presentation. So I encourage you to just take note of the metaphors, chew on them a little bit, think about some of the programming that you find interesting. And really throughout this presentation, I'd like you to keep in mind why engaging caregivers and families is so essential to the work that we do with our patients. Next slide, please. Next slide, please. Oh, got it. Thank you. So many of us on this call already know that our field, the medical field, is really notorious for using jargon, abbreviations, and acronyms. We're all guilty of this. So I'm going to get a couple of them out of the way right away so we all know what the heck I'm talking about. And then we're going to discuss one word, one definition that is very elusive. It kind of defies logic and learning. And then we're going to get into the metaphor bit and talk about how metaphors really shape our patients' perspective, but also our perspective on why we're doing what we're doing. So throughout this presentation, you're going to hear me say PFRC and CCSP, which for folks that are local here to our Chapel Hill area, a lot of us use those terms interchangeably, which is totally fine. We're inextricably tied to one another, but it's not 100% accurate. So the Mary Ann Long Patient and Family Resource Center, aka the PFRC, is a publicly accessible physical location. It's a space within the North Carolina Bass Knight Cancer Hospital. And it's really the patient-facing physical representation of something much bigger, and that is the CCSP, or the Comprehensive Cancer Support Program. So the CCSP is a program. It is not a department. So I like to think of it as kind of an extended interdisciplinary family. And all of the kind of nuclear families are the different disciplines who all share a last name in the CCSP. We often all gather together in one place. Of course, that place is the PFRC, but most essentially, we are all united in our vision and purpose, and that is to provide comprehensive, supportive care to our cancer patients and their caregivers. So those nuclear families include folks from the Lineberger Comprehensive Cancer Center, UNC Healthcare, the schools of medicine, nursing, public health, and social work, a whole fleet of volunteers, and even and often former patients and caregivers themselves. So why am I spending time kind of worrying about the names that we use and the words that we use to describe ourselves? Because language matters, because cancer is not part of an everyday conversation unless you are, number one, on this call, which means you're likely involved in the medical field or in some way providing cancer care. Or number two, you are unfortunately on the receiving end of the C word. And defining that word is, as most of us know, nearly impossible. It's like this multi-headed, unpredictable, highly manipulated concept that we and our patients do our best to kind of boil down into digestible pieces. But ultimately, and at its core, it's one of the scariest words that a person can hear, with some of the most life-changing implications. So if you read this definition on the slide that I borrowed from my first Google hit, which happened to be the Mayo Clinic, which is a great source of information, you'll see that by the second and third sentence, the Googler has already learned that it will probably get worse and that they will likely die. And from that point on, cancer diagnosis, prognosis, treatment might as well be a foreign language. And it often remains so for much of the patient's experience. So here, I think, is where metaphors can come in. And I think a metaphor is really an attempt to understand something new or complex with language that actually has meaning to us. Of course, I think some metaphors are better than others in describing and helping our patients understand, and better yet, actually taking some control of what comes next. But first, I want to talk about the two most common metaphors that I hear almost every day, and admittedly, I use myself. So, number one, the C word launches our patients and their families on what we often describe as a journey, albeit one that is unwanted, often difficult, sometimes rewarding, but usually bumpy, twisty, towards some unknown destination, although we all hope that destination is survivorship. But it has so many possible detours, and like we learned just now, ultimately death. So basically, a really arduous journey that we may not be fully well prepared for. The second metaphor we hear a lot, number two, is a battle, which by definition is an unwanted thing. And that battle requires a momentous and heroic effort, weapons that are often dangerous in and of themselves, and unintentional but sometimes implied ability to quote unquote lose or fail if the victory over the enemy is not achieved. And like I mentioned a minute ago, both this journey and the battle happen in what feels like a foreign land, and our patients have no idea when they'll be home again. And for those of us that have traveled to foreign lands, we know that even if we do know the language, nuance is often lost. Our eating, sleeping habits change, the way we get around, our transportation changes, our daily schedules, our exercise, etc. All of that changes. And of course, it's exceptionally expensive. So this is not like a dream European vacation that we've planned and saved for many years. No, we're lost, we're broke, and now we're sick. So don't worry, I'm not going to stop here. We're actually going somewhere, no pun intended. So just hang in there. What I'd like to do today is introduce two new metaphors, which have been incredibly helpful to me as I've sought to understand who we are in the CCSP, what we're doing, and why supportive care matters. I believe that these new metaphors can provide a healthy antidote to the unwanted journey to a foreign land to fight a battle that our patients didn't seek. So for anyone who practices mindfulness, grounding your experience and your understanding and noticing the quality of everyday things like the table you're sitting at right now, the chair you're sitting on right now, the way the floor feels underneath your feet, the taste of your breakfast this morning, or the quality of the air in the room, can be an incredibly powerful way to kind of break out of that cycle of constant stress we're in, but also a really comforting experience. Because real life happens with real everyday things. It happens with our families. It happens in all sorts of weather, but often it's sitting around something as everyday as a kitchen table. I think starting there is exactly the place to start and the best place to meet our patients. Next slide, please. So we're going to start with an everyday thing called an umbrella, which structurally is all about connection, and functionally it protects us, at least in part, from elements that are outside of our control. So we're going to break this down a little bit. Structurally, each panel of the umbrella may be a different color, a different pattern, even a different material, but they are only functional when they are all joined together. So this is structurally what comprehensive support programming is. It's not a single department and it's not a single discipline. It's an umbrella organization, which at UNC we call the CCSP. Functionally, the supportive care umbrella that opens up and over and around our patients is what keeps their head dry and their core warm, even if their feet and pants still get wet. Cancer, if we think about it using the metaphor of a storm, is like a 100-year storm or flood or whatever is happening in California right now. It's crazy. So the supportive care umbrella may not keep our patients completely dry, but it does keep their head dry and their head above water. Next slide, please. So like I referenced before, the CCSP supportive care umbrella connects our extended interdisciplinary family. At this point, honestly, we need more like a picnic shelter, but you get the concept, hopefully. And just please note that at the center of the umbrella is our patients and their families. So in other words, we can't function without them. We would not be connected without them. Their needs are actually what connect all of us together. So those nuclear families or disciplines are psycho-oncology, caregiver support, integrative oncology, oncology dietitians, the adolescent and young adult program, Get Real and Heal, survivorship support, supportive care navigation, which happens in the PFRC, legal pro bono clinics and the Cancer Patient Assistance Fund, and research and statewide engagement. And the function of that is really to constantly improve and extend our umbrella design and function. But again, all of us share a last name. All of us are dedicated to what we like to call the concept of wraparound care. That means that we are here to help address those everyday, real life ripple effects that happen when the word cancer is spoken. So I'm going to briefly talk through some of these umbrella panels, starting with psycho-oncology. Next slide, please. Which in many ways is at the heart of who we are and what we do in the CCSP. So psycho-oncology services include counseling, psychiatric care, medication management, and very importantly, family and caregiver support. This type of care can be provided by and is coordinated by a very interdisciplinary team in and of itself of psychiatrists, psychologists, advanced care providers, licensed clinical social workers, nurses, and supportive personnel. Research has shown us that cancer patients experience both psychological distress and psychological disorders at significant rates above the baseline commensurate with the general population. And that's due to the nature of their diagnosis and the stress of their treatment. The most common psychiatric disorders we see in our cancer population are adjustment disorders, depression, anxiety, delirium, sleep disorders, psychosis, and psychosocial dysfunction. It's clear that left untreated or unaddressed, and I think we all know this inherently, these types of mental health issues can and often do lead to poorer outcomes in relation to the actual cancer. The good news is that systematic distress screening for all patients with a cancer diagnosis has been mandated since 2015. And when it is done well and consistently and equitably, it allows us to match resources, which we all know are not inexhaustible, to the patients who need it the most. Since we also know from the research how important having a support system is to prognosis and outcomes in cancer. In other words, those patients who perceive or report already having a strong social network seem to have better outcomes no matter what type of cancer they have. Because of these two things, I believe it's vitally important that we're screening both for distress and also evaluating our patient support systems at diagnosis. And this is something that we're piloting in our new proactive outreach navigation. In other words, we know that not all patients are coming into this with a protective and strong social network. And I think of that kind of like a really good raincoat. So it's really important that we open up this umbrella around our most vulnerable patients as soon as possible once that storm hits, so that we can really set them up for and support them during treatment. Next slide, please. Speaking of support, let's talk a little bit about caregivers. So filling in the lines a little bit of what I was just mentioning regarding a strong support system and how that actually leads to better outcomes. We know specifically that having strong caregiver support leads to less healthcare utilization by our patients, better compliance with treatment, and increased quality of life. However, on the flip side, we also know that the societal value of unpaid caregiving is estimated to exceed $470 billion annually. That is just inconceivable to me. And in addition, the financial burdens that caregivers face can be astronomical, especially if they face loss of employment or insurance because of their caregiving responsibility. So what does that mean? It means that as a society, we really benefit immensely from this caregiving that happens, but we don't always recognize its true value nor its true impact. Research shows us that up to 40% of caregivers also have medical or mental health comorbidities that often get worse while they're providing care to a family member. And those additional burdens of their own medical care, their own mental health care, and things like household tasks and personal care are often neglected. A recent meta-analysis showed that the prevalence of caregiver depression and anxiety specifically was at 42 and 46% respectively. If that is not statistically significant, I don't know what is. So it's really clear to me that supporting the caregiver who supports the patient is not just the right thing to do, but it's absolutely essential in our pursuit of improving outcomes for our patients in cancer care. And this is really why all of our relevant supportive care programming, including psycho-oncology care, is and should always be available for both the patient and their caregiver, along with support that's specifically designed for that caregiver, such as support groups of their own, education, and tools for self-care. Next slide, please. So we're going to turn to a unique set of patients who are often in the throes of caregiving themselves, often caring for young children. And this is our young adults and also our older adolescents who are facing cancer and treatment before, during, and kind of throughout what we as a society often consider the most productive time of life. But in the best of times, for those of us who may be in this phase of life, we know is often the most stressful. So having an understanding of the impact and the implications of a cancer diagnosis and the proposed treatment for it within this age group is really important. A recent analysis revealed that most survivors between the age of 18 and 39 shared their concerns that the psychological, emotional, and cognitive effects of treatment on their physical and emotional development, their ability to establish a new identity after having cancer, establishing relationships, parenting, dealing with the financial burden of treatment, and effects on their fertility were all shared among this group. And according to the National Comprehensive Cancer Network, the short and long-term toxicities impacting otherwise young and healthy and independent patients, including those with fertility concerns, often disincentivize treatment, which of course leads to gaps in adherence and poorer outcomes overall. So paying attention to and providing interventions for these issues and providing options that empower these special patients when they are diagnosed may result in better adherence and better outcomes. In other words, how can we preserve fertility, optimize their ability to continue work and plan for their professional lives, support parenting and intervene on childcare issues, and do all of this early on? I believe we can make it more likely that these young adults can make it through treatment. Survivorship and life after treatment is also unique among this group, as long-term effects of treatment can, of course, affect their ability to work, thus their financial stability and their earning potential, of course, their fertility and family building, as well as long-term surveillance and screening adherence. Not quite yet, Tim. Some challenges that can result are communication, lower participation in clinical trials, the need to continually screen for other cancers, and then, of course, treatment adherence. So again, the unique needs and approaches to this group is really a lecture in and of itself, and definitely one that I'm not qualified to give. But it's important and impactful enough that UNC has dedicated an entire interdisciplinary team with special programming just for this population. So how about when treatment ends? Next slide, please now. As of January 2019, an estimated 16.9 million Americans, mostly over the age of 65, were living with a history of cancer. By 2030, this number is expected to exceed 22 million people. Although it is very much worth noting that unfortunately we are still facing incredible inequity in survivorship as well as cancer care. And we know that early detection and treatments, which have benefited so many, still represent a gap for for those who are the most socioeconomically disadvantaged. In fact, from 1991 to 2016, the overall cancer death rate declined by 27% overall, but the socioeconomic disparities in cancer mortality actually got bigger. And unfortunately, the most striking disparities are in those cancers that are most amenable to prevention and early detection. So we have a lot of work to do. So getting equitable care early in all of these areas can only help with outcomes and survivorship for all. But survivorship is not just about surviving treatment. It often comes with many of its own challenges, including complex comorbidity management, long-term physical and psychological effects of treatment, and let's just say it out loud, the ever-present fear of recurrence, and a lifelong and often very expensive relationship with the healthcare system. So ideal supportive survivorship care may not actually look that different on the surface as ideal supportive care during treatment. But of course, the challenge is providing it to a growing number of people in an equitable, compassionate, and accessible way. So it does have to look a little bit different in terms of delivery, frequency, and intensity. It comes, of course, with ongoing surveillance, screening for other cancers, addressing long-term side effects, caring for mental health, continuing to address financial concerns, but also lifestyle and kind of health style support and changes such as tobacco cessation and diet and physical activity support. So perhaps as the storm kind of abates, it's like taking one of those miniature umbrellas with you that you can fold up easily and put in your purse or your pocketbook or your glove box, and it's there whenever you need it. Next slide, please. So returning kind of to the essence of our metaphor, this particular panel, I think, is instructive. So hopefully you're starting to see, or you already know, that supportive cancer care is not just additive or optional, it's essential and it's evidence-based care. So the research and statewide engagement that the CCSP and other comprehensive cancer centers provide are really what allow us to constantly improve the design, the strength, the resilience of our umbrella, but also to widen the coverage area. So we're researching and we're reaching out at the same time. We're learning more about how to do this even better. And then whenever possible, we're finding and providing those engaging platforms and venues to do it in. So you'll see here just some of the areas that we've been able to make that connection and create a statewide community to really bring supportive care to those who need them. Again, this could be a whole separate lecture in and of itself, but is definitely one of the key strategic goals for the CCSP. So we know now that support is essential. And hopefully we also inherently understand that where, when, and how that happens is just as important. Having a safe, secure, and accessible place to do the work is that place where we welcome our patients in from the storm, so to speak, shake off the umbrella, and sit at the table, which in the case of the medical center here at UNC is the Patient and Family Resource Center. So we're going to move on to our second metaphor for today, the kitchen table. Next slide, please. So not everyone comes to the table or any table in the same way. Some people bring a wheelchair and move away the chair so that they can have a place at the table. Some people collapse on the table and some people enthusiastically run up to it. But regardless, at the table, everyone is welcome. The table is an even surface at which we are all sitting on the same level and on which we can all work on and work out those everyday things that continue or cease or change when you have a cancer diagnosis. For example, planning out and eating meals, budgeting and figuring out how in the world to pay the bills, doing your homework, planning your schedules, including time for exercise and self-care. Sometimes gathering around that table and having really hard conversations with your family, and sometimes praying with your spiritual community. But the table also represents a gathering place, a community. This is where you find that hot cup of coffee on a cold day, or a crossword puzzle, or a good book. And in the PFRC, the table also represents a massage table, which is a powerful and effective place for our oncology-trained massage therapists to bring physical and mental relief to our patients, and yes, to their caregivers as well. And regardless of the treatment location, any place, even a corner that provides a soft landing, a little bit of privacy, and some peace and quiet away from the chaos of the clinic is a truly powerful antidote to just about anything. It's worth noting that these days the table can be and often has to be virtual, but I do think it requires much more intention on the part of the host to make it just as meaningful. Next slide. So we're going to spend these last few minutes together exploring what's on the table. And you'll notice that my metaphors are starting to get a little tiny bit messy, so just bear with me. We'll get through it. Next slide, please. So we've all heard the term food is medicine. And in oncology care, this could not be more true. And there are two key aspects that I'd like us to consider here. For those patients who come to the table with food insecurity, which unfortunately is a number much higher than we often realize, coming into treatment with nutritional deficiencies is already a risk factor. And the inability to maintain good nutrition because of financial toxicity augments this risk significantly. And research has shown us that early recognition and intervention for nutritional needs can significantly impact outcomes. So whether it's financial support to offset other expenses, or whether it's actual food or food vouchers or connections to local food banks, addressing food insecurity with any or all of these means can make a significant impact on the outcomes of cancer treatment. The second nutritional aspect I'd like us to consider is that not only can cancer and its treatment affect your appetite, burn your taste buds, cause nausea, vomiting, etc., it can also functionally disrupt your body's ability to swallow and digest food. So having the deep knowledge and expertise of oncology-trained registered dietitian is, and I think should be considered, an essential part of cancer care. These colleagues can recognize early warning signs, recommend alternative feeding methods, prescribe medical nutrition and supplements, educate our patients on eating well throughout treatment despite side effects, and create nutritional plans that are specifically tailored to address the patient's unique metabolic needs. And for our diabetic patients who have cancer, I personally believe that a registered oncology dietitian should be a mandatory member of their care team. Next slide, please. So here we are at the kitchen table still. And now we're in a situation, now that dinner is over, that most of us can relate to. And we're facing a pile of unpaid bills and perhaps an unbalanced checkbook. It goes without saying, of course, that cancer care is expensive, and the complexity of the medical billing system can overwhelm even those of us who consider ourselves medically savvy. If you add onto that the potential loss of income, loss of insurance, or pre-existing debt, it can quickly become debilitating. Financial navigation is a term that is tossed around a lot, but in this context, it's important that we not only help our patients understand the bills and their insurance if they're lucky enough to have it, but also the internal and external resources that are available to help them with specific things like gas, food, lodging, bills, ride shares, home delivery, etc. And also copay and medication expenses through many community and disease-specific foundations such as the Leukemia and Lymphoma Society. Our patients are coming to the table scared, sick, and overwhelmed. So facilitating these connections and actually helping them navigate through the paperwork and the application process can literally mean the difference between a patient getting a life-saving medication for free or crippling debt or non-adherence to the treatment plan. So you might be like me and money is your least favorite subject, but for our patients, it's unfortunately an essential part of their care plan that simply can't be ignored, nor should they have to navigate it alone. We know maybe a little bit counterintuitively that it's often the working poor who are most drastically affected by financial toxicity. They may not present to the table with completely empty pockets. Maybe they have a little bit of food in their belly. Maybe they even have less than wonderful insurance, but navigating their everyday expenses is already an everyday burden before their cancer diagnosis. And cancer can easily and quickly just send them into a spiral of impossible choices. And while we're having tough conversations, let's talk about advanced care planning, which at its very heart is a conversation with the patient and their loved ones, and a really wonderful opportunity for them to come together. It's our job to provide the context and the guidance and the process required for things like advanced directives, healthcare powers of attorney, last will and testaments, and custodial paperwork. And of course, this is a really difficult and sensitive issue to approach, depending on when you are having that conversation with your patient. If it happens right after they've finished Googling the Mayo Clinic site, that might not be the best time. But it is incredibly important that we encourage our patients to talk to their loved ones when they have the capacity and the relative emotional perspective to do so. This can prevent so many heartbreaking scenarios, and I'm confident many of us on this call have seen these all too often, where we have family members torn by decisions that they don't feel confident about. Legacy planning provides a peace of mind that is truly invaluable for our patients, the patient who's facing that potentially terminal diagnosis, but also to their families who will have the tools they need to honor their loved ones. Next slide, please. All right, we're going to break the tension up a little bit here. Our time is getting short. So metaphorically, we're going to get up from the table and move around and also see how many of you are still awake. So research shows us that exercise interventions can reduce the negative impact of treatment-related symptoms and also improve function for patients living with and beyond cancer treatment. So exercise is just one part of what we think of as a lifestyle, and that also includes nutrition, recreation, spiritual, and wellness practices. Integrative oncology and exercise programs aim to optimize health, quality of life, and this is important, improve clinical outcomes across the cancer care continuum. What it also does, these types of programs, are to empower patients to become active participants before, during, and after treatment. So think of it like conditioning. We know that cancer treatment always takes a toll. But if you're fortunate enough to enter cancer treatment in otherwise good health and wellness, then you've already trained your body, your mind, your spirit to have greater strength and stamina to weather the storm. Thankfully, those of us who maybe approach from a weaker space can actually get stronger through the storm with careful, mindful, and professional guidance. So the physical, psychological, spiritual, and emotional benefits of exercise and focused wellness practices are often referred to as complementary medicine. And that's really just to differentiate them from the traditional things that we do to our patients. But they are essential practices that patients can actually do for themselves that gives them incredible agency and the ability to take control of what they can and improve both their experience during treatment and their outcomes from treatment. So I think we have time for this. I just wanted to offer a little bit of a freebie here. It's really easy to do and it's really easy to share. Never done it in a group setting like this, so bear with me. I'm not a certified mindfulness coach, but I'd like for everyone on the call to take a moment, put down your phone if it's in your hand, and close your eyes. Make sure your legs are uncrossed and that your feet are flat on the floor. And rest your hands wherever they comfortably land. Now, I just want you to notice if perhaps your tongue is stuck between your teeth or on the roof of your mouth. And if it is, I want you to just try to release it to a neutral position. Good. Now I want you to notice if your jaw is clenched. And if it is, try to find a neutral or a relaxed position for it to rest as well. Now with your eyes still closed, draw in a deeper breath and raise your shoulders up towards your ears. And as you breathe out, see if you can drop them just a little bit lower than where they started. Let's do that one more time. And now check back in with your jaw and your tongue. See if they need another conscious release. And now when you're ready, open your eyes. I'm going to invite you back to the table for just a moment. We've got just a little bit of homework to do before you go back to work. But I do want you to notice whatever stress and tension you were just able to let go. And consider how doing that between every meeting or on the top of every hour could potentially change the tone and the temperature of your day. Next slide, please. Okay, so we have a little bit of homework. I definitely threw you guys some softballs here, but I really want to encourage you to ask questions of your own, and hopefully we can have a good discussion in the next few minutes. And wow, you guys are already doing great. So the question is, what are 3 issues that can directly impact both the patient and caregiver? I suppose I should have designated this as a multiple choice question. So this might be my bad, technically. You guys are nonetheless doing awesome. All right, every single one of you is correct. The correct answers were A, C, and D. All of those financial, physical, and psychosocial issues can equally affect both the patient and the caregiver. Great job. Next slide. All right. This one should be easy. You guys are killing it. Perfect. All right. Again, a multiple choice question. I'm not sure I let Tim know that's what my plan was. You guys are doing awesome. All right. Next slide. Which of the following are considered key elements of supportive cancer care? All right. Once again, 100%. Thank you all for your attention, your patience with all of our technical issues. These are my references I'm happy to share. And I look forward to any of the questions that may be on your minds. Thank you so much.
Linnea, thank you. That was a wealth of information. We really appreciate it. I'm going to encourage everyone in our audience to go ahead and start sharing your questions. I have a bunch myself, but I'll try not to monopolize and let me just move so that I can moderate and allow those questions as we see those come in to be promoted. Let me ask you first, you had talked about piloting proactive outreach navigation. Do you have a moment to talk a little bit more about what you're doing there?
Yeah, I would love to. So we have a new program at UNC and at Rex called the UNC Health Cancer Care Navigation Program. So that currently is a team of 9 plus a lot of collaborators within the clinical spaces. And this team of nurses and a new position that we call the Oncology Patient Navigator, as well as volunteer support, are proactively reaching out to patients right now within specific disease groups and specific locations at Rex, but reaching out to our patients before they even come in for their first consult appointment. And the purpose of that outreach is really to identify and address any barriers that we can effectively address as far upstream as possible. So those things like, distress, of course, is not an uncommon thing in this space, but really identifying which patients need that extra support early on. Things like financial burdens and transportation issues that could potentially prevent that patient from even accessing care in the first place. And we're already seeing the fruits of our labor. We've been doing this work for about a year. Different pilot groups, and we're really showing that we are impacting these patients in terms of increasing the likelihood that they are able to show up for that first support appointment and initiate their treatment. And then we are continuing to provide that supportive care on a proactive basis. In other words, we initiate the communication with our patients and make sure that we are reassessing the supportive care needs on a continual basis, because we know that things can change very quickly. If you think of a patient who maybe is employed and insured when they start cancer care, and then due to the nature of their treatment, they lose their job and suddenly have a whole set of different needs. And our hope with this navigation program is we'll really be able to capture that when it happens and intervene as soon as possible.
Wow, that sounds amazing. And hopefully we can have you back at some future date to talk about that program and check in on how it's going. We'd love to hear more. We had another question. Early in your presentation, you mentioned different groups that are part of the CCSP, but did not mention pharmacy. They seem to be an integral part. Why?
Wow, that's question. So pharmacy is absolutely an essential part of the care team, kind of writ large. To your point, it is not officially part of our kind of supportive care programming, which again is really kind of focused on the everyday impacts of navigating life with cancer. But kind of one step away from the actual medical treatment of that care. Of course, we interact with our pharmacist colleagues often, and usually our role is, kind of on the front end, ensuring that our patients are able to pay for their medications, that we can help navigate the process by which they need to apply for assistance to make that happen, to help facilitate some of those copay assistance programs or medication assistance programs. And in all of those activities, we're definitely collaborating with our pharmacy partners. So nothing's off the table. I think we would absolutely encourage even more collaboration in that space. But I appreciate the question.
Great. Thank you so much. And I just want to interrupt briefly to give a shout out to the fact that we had 113 people attending today, which is phenomenal. So this must have, this topic and your expertise clearly have resonated. So thank you for that. And thank you to everyone who's attended. Another question, are you rolling this out across the state at all UNC Cancer Center locations?
So I'm not sure if this question is related to the navigation work I just described or our CCSP programming.
Based on the timing of when it came in, I think it's probably the CCSP.
Okay. So that's kind of a tricky question. We're, our strategic mission is certainly to engage with all of our partners, our affiliates and our other cancer centers across the state, because we do exist to serve the people of North Carolina. So the short answer is yes, that is absolutely our goal. The devil, of course, is in the details. So we are definitely finding those opportunities, especially with some of our, virtual and telehealth type programming, that we can kind of branch out and serve people who are not, physically attending our locations. We're not quite there yet. We definitely have some work to do. But I'm just going to say the short answer to that is yes, eventually. That is absolutely our mission.
Great. And let me tag on and ask, how do you all interact with, whether within the UNC system or with other healthcare entities within North Carolina, do you all interact with other peer organizations? Do you mentor peer organizations? What does that look like across the state?
I think there are definitely some folks in the CCSP that are well qualified to answer that question. I'm not necessarily that person. I do know that a lot of our research, efforts are definitely with partnered institutions, even the dark blue one across the street. So yes, but I'd be happy to connect you with somebody that can really answer that question in a more robust way.
Great, thank you. And then I think we all like the metaphors. Do you have any other metaphors for cancer, for the cancer experience itself, other than the journey or battle? Also, it's such a challenge to use cancer survivor, thriver, not really sure what other words have been used. Any ideas? Great question.
That is an absolutely fantastic question. I think language is super powerful, and I think, again, using everyday language is a really effective tool, as opposed to kind of these bigger concepts when you're looking for a good metaphor. For the survivorship piece, a more negative metaphor that I think of often is, the felt experience of a survivor when they finish treatment and then they just kind of fall off a cliff. I've heard that a lot from people, feeling that difference between being so intensely monitored and connected with their healthcare team and then suddenly kind of losing that context and kind of being on their own. So I think, I don't have a perfect metaphor for that yet, but I'll take this as a challenge going forward, finding a good way to kind of ease into survivorship in a way that doesn't feel so abrupt. would definitely be a metaphor that I think we can work on. So whoever asked that question, reach out to me and we can work on it together.
That sounds good. Thank you. We are reaching the end of our hour, so I want to give a tremendous thank you to the people of North Carolina for their generous support through the University Cancer Research Fund of this program and of the UNC Lineberger Comprehensive Cancer Center. I want to say thank you to Veneranda Obore, John Powell, Oliver Marth, Andrew Dodgson, Nadja Brown, and Patrick Muscarella, the team here with the UNC Lineberger Cancer Network, for all of their hard work to make this and all of our other lectures happen. As always, we have many new lectures. I'm so excited. We are already booking this series into 2024 and are mostly booked up for our other series throughout the year as well and into the next year. We're working on that. Next APP, the value of integrative medicine and oncology care. Boy, what a great follow-up to your presentation, Linnea. This is with Denise Spector. Then our next R2P, multidisciplinary, multimodality management of locally recurrent rectal cancer. We're getting that multidisciplinary piece in there with Jose Gulliam. And then our CISEP, the next one in our CISEP series, closing the chasm between Native community priorities in cancer prevention and healthcare research priorities with Siobhan Westcott. So lots of great programs coming up. Hope you'll be able to attend all of those. CISEP is a collaboration with Duke and Wake Forest that we're really happy to be a part of. We're always adding new enduring materials, and we actually are bringing back 2 of them for a second year. These have been tremendously popular, Sex and AYAs with Cancer, Mitigating Risk and Managing Sexual Dysfunction and Oncologic Emergencies. And then we just added American Indian Cancer Control and Health Equity. So 3 great programs that you can go and take freely anytime, day or night, and receive credit for those. For anyone who needs to reach out to us with questions or to troubleshoot or problems getting credit, any of that, unclcn@unc.edu or 919-445-1000. We're on Facebook, we're on Twitter, we're principally on the web, so find us in any of those places. Linnea, thank you so much. This has been amazing. We've learned a lot. I've learned a lot. Hope to have you back again sometime soon. And thank you for all the wonderful work that you do. I'm really glad to have you here.
Awesome. Likewise. I couldn't do it without you and your expertise as well, Tim. And thank you, everyone, for your time and attention today. I really appreciate it.
Absolutely. We loved having you all here. Thank you for being such a great audience, and we hope to see you all soon. Take care. As soon as we end this, you can go ahead and claim credit if you're planning to claim credit. Follow the steps we talked about at the beginning, and we'll hope to see you all soon. Take care, everyone. Bye-bye.